Hello friends, in today's episode we'll be talking about CTG, cardiotocogram, or NST, non-stress test. Now the difference between non-stress test and CTG, let me tell you once again. Non-stress test is when only the fetal heart tracings are taken, but there is no obvious cardiotocography, that is, you are not taking tracings of the uterine contractions. But in a CTG, you are taking tracings of the fetal heart rate as well as you are taking tracings of the contractions. So in exams, it is very much obvious that in Viva exams, you will be asked about CTG or NST. So how to interpret it, it is very important to score good marks. Now check. When you are given a CTG trace, you will start like this. This is a cardiotocogram showing fetal heart rate baseline of around 140 beats per minute. You can check in this. The fetal heart rate is traced in a unit of beats per minute, whereas the uterine contractions are traced in a unit of Montevideo units. So if there can be mild contractions, there can be moderate contractions, there can be severe contractions or hyperstimulation. Now this fetal heart rate baseline is around 140 beats per minute. Variability is reduced, that is around less than 5 beats per minute. There are two obvious accelerations. We say accelerations when the heart rate increases by 15 beats per minute and remains for at least 15 seconds. And there are no obvious decelerations, because decelerations are also defined as decrease in heart rate by 15 beats per minute and which persists for more than 15 seconds. So this is the initial trace or recording which you say. But then we have to refer to the 2015 guidelines. Now let us once revise the 2015 guidelines, what it says. So you should remember, as you can see in the picture which is shown here, first we divide the CTG tracing into reassuring, non-reassuring and abnormal. Mind you, the terms are RNA. The mnemonic is RNA, reassuring, non-reassuring and abnormal. So for each term, you have baseline, variability and decelerations. So in reassuring, the baseline will be between 110 to 160 beats per minute. Variability will be between 5 to 25 beats per minute. And there will be no deceleration or early deceleration or variable deceleration with no concerning features for less than 90 minutes. Now, let us see what are concerning features in variable decelerations. So, concerning features are 5. If one deceleration is of more than 60 seconds, or there is reduced variability within the deceleration, or there is absence of shouldering. Shouldering means in the front part or the back part of the deceleration, there is no acceleration. If there is failure to return to baseline after a deceleration, or there is biphasic pattern or W phasic pattern, that is two decelerations coming one after the other spontaneously, then they are said to have concerning features. So what we found is, if there is no concerning features in less than 90-minute trace, then it is reassuring. For non-reassuring, the baseline will be between 100 to 110 beats per minute, or there will be tachycardia of 161 to 180 beats per minute. Variability of less than 5 for less than 50 minutes, or more than 25 for less than 25 minutes. Or in deceleration, there will be variable deceleration with no concerning features for more than 90 minutes, or variable deceleration with concerning features in less than 50% of the trace for more than 30 minutes, or variable deceleration with concerning features in more than 50% of the trace for less than 30 minutes. In abnormal features, you have baseline of less than 100 or more than 180, variability of less than 5, that is less variability for more than 50 minutes, or hyper variability, that is more than 25 beats per minute for more than 25 minutes. And in decelerations, either you have variable decelerations with concerning features for more than 50% of the trace for more than 30 minutes, or any late deceleration or acute bradycardia of more than 3 minutes. Now friends, let me explain to you what is early deceleration, what is variable deceleration, and what is late deceleration. In early deceleration, you have the deceleration corresponding to the peak of the contractions. It occurs when there is head compression. So in second stage of labor, when the head comes near the cervix and the cervix also grips the head with each contraction, then beside the head there is vagus nerve which gets stimulated, which leads to instant fetal bradycardia, and so it occurs and it gets relieved when the contractions are over. So this is a normal finding, it is a reassuring finding. In variable decelerations, it occurs because of cord compression. So cord can get compressed anytime, so there will be variable deceleration. But what is important is looking at all the 5 concerning features. So whenever you have a trace with variable deceleration, you have to look for the concerning features. Thirdly, you have late deceleration. Late deceleration occurs because of fetal hypoxia. First, the fetal hypoxia will stimulate the chemoreceptors. Chemoreceptors will thereby lead to increase in heart rate, so that there is increase in uteroplacental circulation, and then increase in heart rate will lead to increase in systolic blood pressure, which thereby will stimulate the baroreceptors and thereby decrease to heart rate. So this process takes a lot of time. That is why the deceleration is after the contractions are over. So late decelerations are always abnormal, thereby leading to a pathological CTG and thereby necessitating early delivery. So now let us check the traces which you get. So let us be more vigilant upon the traces. So when you get this type of trace in exam, you say this is a cardiotocogram showing a baseline fetal heart rate of 140 beats per minute. There is a bit reduced variability of around 5 beats per minute, 5 or less than 5 beats per minute. There are 2 obvious accelerations and there are no obvious decelerations. Then you comment on the contractions. So contractions are mild in this case and it is not regular. There are 2 contractions which are seen with the help of arrow and they are not regular. So this patient might be in early labor, and now we will check whether what type of CTG it is. So baseline is reassuring because it is 140. Variability is a bit reduced, less than 5. So it might be non-reassuring. For that we have to extend the stretch to more than 50 minutes to say whether it is non-reassuring or reassuring. Acceleration is there, there is no obvious deceleration. So final interpretation will be it is either a normal CTG or a suspicious CTG based on whether I extend the trace to more than 50 minutes. So is it clear? If it is a suspicious CTG, then we will go for oxygen, RL and left lateral position, that is uterine resuscitation. If it is normal, then just continue the labor. This patient is in early labor. Now check this stage. So if it is given in exam, what will you say? This is a cardiotocogram showing baseline fetal heart rate of 140 beats per minute. Variability is around 5 to 10 beats per minute. That is also reassuring. Then there is 1 acceleration and there is no obvious deceleration. Then come to contractions. There are moderate intensity contractions, 4 contractions in 10 minutes. It is a regular contraction. So the patient might be in active labor and CTG trace is normal. It is normal because baseline is also reassuring, variability is reassuring, there is no obvious deceleration is also reassuring. So it is a normal CTG. Coming to this stretch. Now here we will comment. This is a cardiotocogram showing fetal baseline heart rate of 120 beats per minute. There is reduced variability of less than 5 beats per minute. Reduced variability is non-reassuring. But then we have to take the stretch for more than 50 minutes to comment on it. There is no obvious acceleration or no obvious deceleration. Coming to contractions, uterine contractions are also mild and they are not regular contractions, so occasional contractions. So this patient might be in early labor, and this is a suspicious CTG. Suspicious because there is reduced variability. One non-reassuring features, others are reassuring. So this is a suspicious CTG. So what will you do? You will do uterine resuscitation with oxygen, left lateral position, and RL or IV fluids have to be rushed, and then patient has to be monitored after oxygenation. If it becomes alright, normal, if the variability improves, then well and good, we can go for labor. Otherwise, we have to do an artificial rupture of membrane and check whether there is meconium stained liquor or there is fetal hypoxia. Coming to this stretch, when you get this stretch, you comment that this is a cardiotocogram showing a baseline fetal heart rate of 150 beats per minute, variability of 5 to 10 beats per minute. These two are reassuring. Now there are decelerations. There are 3 decelerations which are obvious and 1 acceleration. Now these decelerations are corresponding to the peak of each contraction. So these are early decelerations. There are good uterine contractions, moderate intensity and regular. So this patient might be in active labor, that too may be in second stage of labor whereby there is head compression. So early deceleration is also a reassuring feature. So this is a normal CTG. So nothing has to be done. You have to just do a pervaginal examination and check whether patient is fully dilated. If so, then shift the patient to delivery table and ask the patient to bear down and take a birth attendant along with her, give constant support to her and ask her to bear down. You will go for a normal vaginal delivery. Coming to this stretch, this is a cardiotocogram showing baseline fetal heart rate of 170 beats per minute. Now properly see, this is tachycardia. So 170 beats per minute will be non-reassuring. Then variability is also reduced, less than 5 beats per minute is also non-reassuring feature. There is no obvious acceleration and there are 3 decelerations. Now these decelerations are not corresponding with contractions. So these are variable decelerations. So whenever there is variable deceleration, what will we check next? Whether there are concerning features or not. So we can see there are 2 concerning features. One is there is no shouldering, absence of shouldering. And the second is there is decreased variability within the within the decelerations. So concerning features are also present. So next you will see concerning features if present less than 50% of the trace or more than 50% of the trace. So you can find all the decelerations are having the concerning features. So more than 50% of the trace. So more than 50% of the trace for less than 30 minutes will be non-reassuring if you remember. And more than 30 minutes it will be abnormal. So most probably since this is a less than 30 minutes trace, we cannot comment. We have to extend the trace to more than 30 minutes so that we comment on whether it is abnormal or not. So once it is an abnormal trace, then it will become pathological and you have to do a pervaginal examination and check. If the patient is near to fully dilated, then you augment the labor, accelerate the labor and you can go for instrumental vaginal delivery. Otherwise you have to go for cesarean section. So this is about the variable decelerations. Now this trace will have, what will you say? This is a cardiotocogram showing fetal heart rate of 130 beats per minute, which is reassuring. Decreased variability of less than 5 beats per minute, which is non-reassuring. Then there are decelerations. There are 5 decelerations. And each deceleration is after the peak of the contraction, you can see. So these are late decelerations. Late decelerations are all because of fetal hypoxia and late decelerations are always an abnormal finding. So since there are abnormal finding, one abnormal finding will also be a pathological CTG. So this is a pathological CTG. Again the same thing. If the patient's PV, do a PV pervaginal examination to rule out any cord prolapse, or if there is bleeding, then there can be placental abruption or meconium stained liquor or any other acute event. So rule out all those events. If you find that patient is near fully dilated, then you can shift the patient to delivery table, augment the labor, and you can go for vaginal delivery with instrumentation. Otherwise you have to shift the patient to OT for cesarean section. So this is how we interpret CTG. I have told you in detail. If any doubt, you can ask me anytime. For more information, remain updated and subscribe our channel Medi Mantra.